All right, so I have the optimal time after lunch, right, when nobody's sleepy or anything like that. But luckily, this stuff's so exciting that I have no concerns. So this is our team, and my other two team members are sitting at the table over there. So Danielle and Teshna, who many of you will be speaking with at some point, and I'll give you more of an idea of what you'll be speaking about, hopefully. So quickly, I want to give a refresher on what the objective is for the economic evaluation for this study and why we're doing it. And part of that will be much more informative if I provide some context, a little bit of background on exactly what this stuff is and what we're doing with, what we do with it just in general. I'm going to focus specifically, I should say the most on costing out the intervention itself, because that is kind of where we're at in the process right now and something that we'll need your help with for many of you. To do that, we have this fantastic budget impact tool that we have created. It's Danielle's baby, and she was happy to help with it. And we have a consultation service through CHERISH that I'll tell you a little bit about. And actually, I'll tell you what CHERISH is too. And then, of course, some time for questions. So just quickly, background-wise, we know that opioid use disorder and just substance use disorders in general are very expensive, right, to society, as well, of course, in addition to all of the costs, the personal costs and everything incurred by individuals with the disorder. But if we break this down, so a recent study that I did, we found that the cost to U.S. society on an annual basis are about $800 billion. And that can be broken down into these sections. So you'll see the biggest chunk of that is premature mortality. But even if we take that away, we're still looking at about 90 billion in healthcare expenditures, quote unquote, excess healthcare expenditures, lost workplace productivity, and of course, the criminal legal involvement. And if we break that down and calculate a present value, we see that if we were able to avert, say, one opioid use disorder, the average we could save per individual, like in today's dollars, would be 2.2 million. So the objectives, the economic aim for this study, two parts, really. One is to estimate the cost to the correctional health system of both implementing and sustaining one of these programs, right? Like extended release naltrexone or XR-Butte. And then, of course, to determine the relative value of these strategies, and including the costs that are associated with the subsequent interventions in the community, as well as, I'll talk about here in a minute, some of the downstream cost offsets that we hopefully see with effective treatment. And so we do this from a state policymaker and a societal perspective, which I'll explain here in a second. So the next steps are, like I said, we're kind of at this stage right now where we ideally are going to be costing out the interventions. We have some idea already. We were able to come on some of the early site visits and see some of the facilities and kind of get an idea of the layout. And so now, we'll be following up to gather, make sure we have all the information really specifically on the resources that are required to implement and sustain each intervention. So if we do reach out, we don't need information on costs, actually. We don't need to talk to any finance people or anything like that, because what we're really interested in are those resources. So materials, time, obviously being a big one, and kind of all those things that it takes. And then we will later apply like unit costs, if you will, to them, to like nationally representative costs, or even, more locally representative, if that's helpful. But at any rate, so this is something that we do for each site, and we provide a customized budget impact tool that I mentioned a minute ago, and I'll walk through here in a second. And what this tool does is, first of all, it's really helpful for us just in terms of, because we'll come and we'll talk and we'll take all kinds of notes on the resources and the workflow, and we're talking to different people in the process. And so then it helps us really just organize all of that information and make sure that we have it all together. And then oftentimes sites will find it useful to keep and, to continue to use for budgeting purposes. And so anyways, I'll show you a little bit more about that here in a second. And then what we're going to end up doing with these is we'll estimate both across site and per participant means. And so eventually we'll have a paper that's focused on kind of implementation and sustainment costs. And then we'll have a cost effectiveness paper that will kind of pull that information and bring it all together. And so I'll show you how that works here in a second. Okay, so the thing that I always like to say when it comes to an economic evaluation is, in terms of why do we do it, is it's really, the whole purpose is to inform real world decisions, right? Because we know resources are scarce no matter where you're at. And so what we do as economists is help make the best use of those resources. So how can we take them and essentially maximize whatever it is we're trying to maximize? So, if we're talking about effectiveness and helping people with substance use disorder, the ultimate goal is to help as many as we can with evidence-based treatment. Okay, now here's the thing. We talk about these interventions and how great they're going to be, and they're going to save all this money, and they're going to be better, and they're going to, everyone's going to be healthier, and we're going to save a ton of money, right? Well, I hate to break it to you, but more often than not, that does not happen. More often than not, you're spending more, but you're getting more, right? And so that's kind of where this whole idea of cost effectiveness analysis comes in, because what we're really talking about is comparative assessment of worth, right? And now, of course, that's subjective, right? That's going to depend on who the stakeholder is. And so I was talking earlier about state policymakers versus society versus, say, health insurers. So those are perspectives that we think about at the very beginning. And we say, okay, if I'm, let's say, a policymaker and I need to make a decision on, do I go this route or this route? What do I need to know, right? What kind of costs do I need to focus on? Well, there's healthcare, right? Medicaid obviously pays for that. There's criminal legal resources. Those are going to be paid. There's going to be social safety net programs. And there's going to be, maybe some of these other relevant pieces. And in the end, what I want to know is, since I'm really responsible for this entire budget, which one is going to give me the best value? Because if the treatment's effective, we do think we will see offsets. It may not completely offset, but we should see some offsets in some of these categories, right? As well as an increased effectiveness. Okay, so those are, anyway, so that's kind of that perspective piece, things we want to keep in mind. Because again, the whole idea is like, how do we use these resources? So theoretically, cost effectiveness analysis is pretty straightforward, right? What we're really doing is we're taking, let's say, the mean cost for the intervention, subtracting the mean cost for the control group, right? And dividing that by the mean difference in effectiveness. So let's say that, so a common outcome that we use in economics for cost effectiveness analysis is a quality adjusted life year. One quality means like 1 year of perfect health, essentially, right? So the idea would be the intervention is going to cost us an additional, say, $50,000 per year to get one additional quality adjusted life year. Now, granted, we also usually will look at clinical outcomes. So say time abstinent from opioids, or, we can look at these other things. I won't get into the reasons we choose one or the other right now, but the point is, this is kind of the ultimate outcome for the economic evaluation is the ICER. And we'll have one for each effectiveness measure that we choose. So the quality, maybe, like I said, the abstinent year, we call it usually, and any other outcome. And then, so like I said, before we get to that point, though, we need to fill in those intervention costs, right? Well, not just the intervention costs, but all of those costs that pertain to that perspective. The first one, of course, being the intervention cost. And so this is from a different study that we did. This was the CTN 51 XBOT study, for those of you who might be familiar with that. But at any rate, there were these 8 sites. And so we went and visited all of them and did the intervention costing. And so there's a paper, as you can see at the bottom here, that will give more information. But I just want to give you an idea of kind of what type of thing we do, what we do with these data. So we'll break it down by whatever relevant costs, for each site. And then, of course, we'll look at that across site. But the one that will eventually go into the cost effectiveness analysis is usually like a mean cost per patient, right? Because we're doing these at the patient level. But so these types of papers in and of themselves are very, I think, interesting and helpful, just to see across sites what are the different models people are using for a particular intervention, kind of what are the costs associated with those different models? And then of course, did one site maybe have more success than the other? And is this something we should look at? So in the end though, we take that intervention cost. And then like I said, we're also measuring the cost from these other sections, right? So again, this same study, the costs were grouped by the intervention, right? Any other opioid use disorder therapy outside of the intervention that was received, criminal legal costs, and then total costs. Okay, so we can see in this case that the intervention was more expensive, right? And then down below, you can see the outcomes that we used in this study. So again, the quality adjusted life year, as well as the abstinent year, which is just essentially the predicted proportion of the year that the individual was abstinent from opioids. But so at any rate, we look at those separately, and then we combine them into the ICER that I showed before. Now, what I always tell my students is if you come away from this talk with just one thing, hopefully it's that, you realize cost effectiveness, just the word cost effective is typically used incorrectly. And now you can start, telling people, correcting them on how to use it correctly. So the term cost effective, as this relatively old quote says, it's rarely correctly used. You'll hear it surrounding almost everything related to money and healthcare. So what it doesn't mean is cheap, nor does it mean that something's cost saving, right? So like I said before, more often than not, we pay more to get more. And so when we get that ICER, the easiest way to think about it is in the context of this, these different quadrants here, right? What we call a cost effectiveness plane. And where we're going to focus on right now is in that top right corner, the one that says review, because you can see in those other two, those are kind of your no nonsense corners. Like this makes perfect sense. We don't really need to go much further. So the one in like the upper left is saying, well, the intervention saves money and it improves health, right? So, okay, well, that's a no-brainer. We should go with the intervention. The other one basically says, well, the intervention actually costs more and it's less effective. Well, if that's the case, then we should stick with TAU or whatever the control is, right? But again, most of the time we're going to end up in that top right corner. So the question becomes, like, what is the stakeholder willing to pay, right? Is this a good deal for them or not? To pay this additional money to get these additional outcomes, okay? So of course, that's a tough question to answer, right? Especially when we're trying to make these results representative. But the cool thing that we can do is we can look at the uncertainty around that, right? While accounting for things like sample selection. So meaning just the sample that we have for the trial may not be perfectly representative of the population, but we have methods to kind of account for that, right? And to be able to look at this uncertainty. And eventually what we can get is something like this. This is called a cost effectiveness acceptability curve. And basically what this says is we can look at a willingness to pay value for any, for whatever that, for a given stakeholder, let's say, and let's say they're willing to pay $200,000 per quality, right? For one additional year of perfect health. Well, how confident can they be that this intervention will fall within that range? And that's what this tells us. So if you look at like that vertical blue line that says 200,000, you can see that, well, let's focus on the dark line, the 25-week intervention, that you could be 60% positive that you would, find it to be a good value at that case. Well, that's maybe too much uncertainty for some. But at any rate, you can see, okay, well, how much would I have to be willing to pay to be really confident? So the point is you can kind of, multiple stakeholders can look at this and say, okay, well, maybe for us, we're not willing to pay that much. This isn't that good of a deal, or maybe it is. Okay, so back to the intervention cost. So that's just kind of the big picture of where we're going, right? This big CEA. But again, the first step is really that those intervention costs and looking at those by site and across site and all of those good things. So how we do this typically is what we call a microcosting analysis, meaning we're basically trying to identify all of the resources. So it's kind of like a bottom-up approach, if you will. So some of this information we may be able to get through administrative records. I mean, we don't want to burden anybody any more than we need to. That's 100% true. But The problem is most of this information can't really be garnered from administrative records. It's most of it will be obtained by like semi-structured interviews and things like that, because again, we want to know like, how are you actually using your time and how is that working? So not just, you know, budgets in and of themselves are rarely accurate, right? When you actually look at it and say, okay, well, I budgeted 50% of my time for this, but in reality, I ended up spending more of it over here versus here. So at any rate, that's kind of our goal, is to just focus in on that resource utilization. And we have this instrument that we follow, and essentially it's a very broad instrument, but we basically use it and kind of help tailor our questions according to the intervention. So this is the DAT cap, which we use, and nothing really to see here other than just get an idea of kind of the different sections. And so the point of this really is to make sure we don't miss anything. Right, this, if you go through it, will cover pretty much anything you could think of to cost out an intervention in pretty much any setting. And so again, but we go through it first, we tailor it. And the other thing that I should draw attention to with regard to this process and the DAT cap is that we're focused on both accounting costs and economic costs. So accounting costs are like those actual expenditures. Right? Economic costs are those actual expenditures plus things that say may be subsidized, right? So opportunity costs is what we call them. And like donated services, volunteer effort, things like that. And the reason being is that those things, just because they're subsidized at a particular site or whatever, doesn't mean that they're going to be elsewhere, right? So for you, that may not be a cost, but for others, it might be. And to make the intervention work, all of those things need to be accounted for. So that's our goal, is really what's it take to make it work. The budget impact tool that I mentioned, I think I've already kind of talked about that a fair amount, so I'm gonna just show it to you. Oh, the one thing though that I want to highlight is that this tool can be customized. So we've made it, you know, not just so it's useful for us, but again, like I said, many sites find it useful, and so we also have tried to make it very user-friendly. And in fact, we worked with one of our colleagues on this, who helped us develop this and is on the manuscript that's hopefully going to be published soon, is a finance person at one of the jails in Massachusetts, and they've continued to use it. So part of the process, one of the things, of course, we need to figure out who to talk to, right? Like, who are the relevant personnel? So essentially, we define relevant personnel as individuals who have the most knowledge of the site's day-to-day operations as they pertain to the intervention. So usually by working with the lead team and, you know, whoever, say, the point of contact is at the jail, we can identify these people pretty quickly. We try then to do an in-person site visit. Those, you know, luckily we were able to do pretty much all of those prior to COVID. Here when I follow Mike and everybody around. And so anyways, so once that's done, we basically are able to estimate kind of those startup costs. So we try to do that relatively early, and that's kind of what we'll be working on first, right? That makes sense. And then at some point, once you believe you've reached a steady state, and we'll kind of work on that just by speaking with the intervention team, or as well as you know, our contacts at any of the sites. Then we'll do just like usually a short follow-up interview to say, okay, well, what changed? You know, because from that intervention point, or sorry, that implementation point to that steady state, basically you're working out kinks and things are kind of in flux. And so eventually we want to know kind of where did things settle out? Yeah, and then basically, like I said, we'll put them into the tool. We'll get in contact again with whoever it is we've been working with and run through it with them, make sure that we're all on the same page, and you know, things kind of line up where we think they're supposed to. So again, site visit, not necessarily relevant for the right now, but you know, essentially what we're trying to do is develop an understanding of the intervention integration process, workflow, again, estimate those resources. And the other piece that's always a little tricky is separating out what's research specific versus real world, right? Because oftentimes there's that gray area. Well, whereas, well, like this really was for, you know, kind of defined more as research, but if we weren't doing this, it would not be as effective in the real world, right? So there's always some of those pieces that need to be teased out. Okay, so as far as intervention cost types, so what you'll see here in a second when I show some pictures from the budget impact tool, once we've gathered that information, we define the resources as one of three types, either fixed, time dependent, or variable. So fixed means these are like your startup costs, right? They're the costs you incur just that one time typically, and then you don't have to worry about them again, right? So they're obviously very important to know what those are and to be able to account for those. But when it comes time to do like the actual cost effectiveness analysis, we don't include them, right? So that's another reason it's important to kind of do this initial intervention costing, is because obviously this is a big deal, it's a barrier, but over time, those fixed costs become negligible, right? And so when we do the cost effectiveness analysis, it's from like a steady state standpoint. So kind of once you reach that steady state, what's the best value, if you will? Okay, so at any rate, there's those fixed costs, then there's time dependent costs. These are basically costs that they're recurring, but they're fixed over a given time period. So meaning like a lease is kind of the best example of one of the best examples of a time dependent cost. If I want to open my business, I have to pay this lease. Once I pay it, I'm good for the month. It doesn't matter if I get 0 customers or if I get 100,000 customers, right? That cost, it's paid, it's done for that time period. Then there's your variable costs. Your variable costs are the ones that are really a direct function of the number of participants, patients, customers that you have, right? So if I'm going to treat more, eventually I'm going to need more, right? I'm going to need more of this person's time. I might even need a whole nother person, so on and so forth. Okay, so those are the different categories of costs. And then there's 2 different phases that we focus on. And those I already talked about. The implementation phase, which we typically define as pretty much everything leading up to that steady state, right? So the planning, the implementing, et cetera, right? And that can be adjusted that time period. And then there's the sustainment phase, meaning we no longer are worrying about those fixed costs, we're just focused on the time dependent and variable costs because, you know, like I said, over time, those become negligible. So how am I doing on time? Okay. Hypothetical example that I want to walk you through quickly here, just to show you kind of how this tool works. So let's assume that we have a correctional facility, and they're choosing to offer all 3 MOUDs, and they're going to use a combination of vendors as well as their own healthcare staff. We're going to assume that the average number of MOUD patients per month would be 123, and that they're going to be split up by 86 on Bupe, 28 on methadone, 9 on the extended release naltrexone. Okay, so the costs are going to be derived from, like I said, the hourly wages and fringe benefits. Those we're pulling from, so the costs you'll see will be nationally representative unit costs, meaning like the hourly wages, fringe benefits, we're pulling those from the Bureau of Labor Statistics. We're using the federal supply schedule for medication costs, things like that. So the tool starts out, you have a dashboard, right? Just to give you an idea of what your costs are. And of course, this can be tailored to whatever costs are most relevant to you. This one, we left most of the things in so that you could see. So for example, you know, we have built in, if someone decides to build a dispensary and become an OTP, or even if they don't become an OTP, but they build the dispensary, that's built in there. Cost for IT, other supplies, meetings, training. So those are all those fixed startup costs. But at any rate, so whatever is relevant can be, you know, put on the dashboard, if you will. So behind that, of course, are these individual sheets. So this is the fixed startup costs that we were just talking about a minute ago. And you can see, like I said, there's a space for construction costs, dispensary, and really anything else that might be relevant. And we're constantly working to make this as useful and relevant as possible. So of course, we're working with you. Something that's not in there should be, or whatever, we're happy to make that change. Let's see. And then of course, you've got your time dependent costs, and you kind of see how those are broken down. You know, again, whether you're hiring a vendor, if there's software systems or annual trainings, vendor supplies, whatever the case may be. Here we can also see in this example that they had, you know, at least initially, while they were, they had to send security personnel as well as a registered nurse to go pick up the methadone. So in this case, they actually had to send 2 security personnel as well as one registered nurse to return the empty vials. They still had to have a security officer and 1 nurse. Again, that varies, and some of that has even changed over time. I know they've relaxed some of these regulations. Anyways, and then we've got our time dependent costs. So again, you can get an idea that it's very much can be tailored to whatever is most relevant for that particular site. And what else? The testing. So at any rate, I'm not going to spend a lot of time going through every little detail, but I'm happy to send the slides, and we're happy to walk you through it or anything like that. So once the tool is actually published, so we're waiting for the manuscript to be published, we'll be actually putting it on our CHERISH website, so it'll be publicly available. And so CHERISH, unfortunately, I forgot to put CHERISH slides in here, but CHERISH is our NIDA-funded P30 Center of Excellence that is hosted at Weill Cornell. And essentially, it's a research center focused on health economic questions around substance use disorder and related conditions. So I am co-director of the methodology core for CHERISH. And then I'm also director of a consultation service that we have. So this consultation service is essentially a resource for individuals who want to incorporate some kind of economic component into their work, and they're not quite sure how to do that, right? So, and we have a group from around the country so we have obviously experts, part of the center itself, then we have what we call research affiliates, which economists from around the country that have different areas of expertise. So just kind of depending on what you need, ideally, we can match you with somebody that has that level of expertise, and you get like 6 free hours of consultation, right? So our grant allows us to pay that consultant for that amount of time. And of course, after that, it would be up to you and that person to continue to work together. But where I can see this being most relevant, especially maybe for this group, would be, say, for this budget impact tool, because we're happy to share it on a one-on-one basis prior to even putting it up on the CHERISH website. And then as far as like using it, tailoring it, that kind of thing, that's definitely something we can assist with as part of the consultation service. Or, honestly, like I said, for anybody that's involved in this grant, we're going to be wanting to do that for the purposes of this grant anyways. So questions, I think I tried to leave enough time for questions, because I realize it's kind of a lot of information and all that straightforward. Yeah.
So like on this slide, for example, does that allow for expansion of patients that can be served per month? Or is that...
Yeah. So let's see, that would be like here. So in the background where we've got like the variable costs, we can adjust kind of how many patients are expected per month on any given medication.
Yeah, I just didn't know if like that facility, for example, if those are like real hard numbers, and like if that's something that they've evaluated, do they have enough staff to even do more patients, or is that kind of like the ceiling? Does that make sense? These are like shocking statistics though.
Right. Yeah. So first of all, this is definitely hypothetical, and there's probably more things included in here just for purposes of kind of showing how the tool would be used. The other thing though is a lot of people tend not to include, say, some of these like fixed costs, or like some of the meetings and the planning that tends to go into the implementation. And then, like I said, when we're costing these out, we're also usually focusing, for our purposes, we're focusing on all costs. So whether that's, so if you have a security guard and X amount of their time is being used for this, for our purposes, we need to know kind of what that cost is. For the facility itself, that may not show up. But, to answer your other question, yes, that's something that we also incorporate, is kind of where's that ceiling at before I would need to hire another FTE or things like that. So
I have one more question.
Yeah.
And that is, so we do a lot of, we're part of the SOAR program at our office, and I do a lot of data analysis every month of every patient who's received a substance use assessment and what substances were being addressed and blah, blah, blah. And it's specific to opioid, and now this past year to stimulant. But a lot of our patients that we're screening have a prevailing alcohol substance, addiction. disorder and may not, or they may have little THC on board or a little bit of, benzos, but there's no opioid or stimulants even involved, but yet they're constantly recycling through our ED, the recidivism in our, detention center services. And so, but I guess I'm wondering about that polysubstance part, is this looking at, I guess I'm curious about the opioid as a standalone problem. And I get that, this is great information, but how then does that translate to other substances, and can it be kind of, translated across the board? Or is that just way out and it's a whole nother research subject? I don't know.
No, I mean, that's a fantastic point. So you're right. The way this is set up right now was designed specifically to estimate. So we're working also with the J-Coin Massachusetts site. And so, they've already been incorporating these and at any rate. So we were able to do a lot of work alongside some of these jails that have already gone through this process. And so the focus was really just on what is the cost of getting this, meeting these requirements of offering the 3 MOUDs in prison and the different, or jail, and the different models associated with that. Do we do it all ourselves? Do we strictly hire vendors? Do we a combination of the two? And so the purpose of this was really to accommodate pretty much any of those combinations and estimate the cost of that particular program. Now, that said, if for a given site, they want to incorporate into this budget the cost of also treating alcohol use disorder, as well as any other substance use disorder, that could be done relatively easily. That's something that would be like a good CHERISH consult thing. We could help incorporate that pretty easily.